This is the group education of the pregnant Hispanic community, University of North Carolina at Wilmington, Nursing 408, Community Assessment Project presentation and PowerPoint by Michelle Lopez, Catherine Sinopoli, and Courtney Soroy. Introduction. The community represented by this presentation is the pregnant Hispanic women attending a low-income OB/GYN clinic in Charlotte, North Carolina. The presentation will look at the demographics of Charlotte-Mecklenburg as a whole, with a concentration on the 28213 zip code. We performed a windshield survey, which reviewed access to public transportation, which they do have. Sidewalks are apparent throughout most of the community. There is a lot of road construction going on, major road construction, so some sidewalks are in poor condition or even closed. There are many apartment buildings and small homes. There are multiple gas stations with EBT signage displayed in their windows. Many closed and even abandoned strip malls and grocery stores, which for these patients provides a limited access to fresh fruit, vegetables, and meats. There are homeless citizens on roadsides and at intersections, and a large presence of police and/or sheriff cars. Demographics, languages. This zip code is 63.3% English speaking and 31.2% Spanish speaking. Other languages represented here include French, Vietnamese, Gujarati, Korean, Italian, African, and South Asian. Ethnicity demographics. Some of the ethnic backgrounds here include highest is Mexican at 19.2%. Following that is Sub-African at 12.4%. Then we have Central American, 10.2%, African at 6.5%, and Puerto Rican at 4.7%. We have two pie charts here regarding marital status and age demographics. And you'll see on the left-hand side, the highest percentage for marital status is single, never married, followed by married, then divorced, and finally widowed is the smallest percentage demographics in this zip code, in this community. On the right, the pie chart shows that both the 30 to 44 age group and the 5 to 17 age group are very comparable as far as percentages, followed by 18 to 29-year-olds. Then we have the 45 to 64-year-old age group, followed by under 5-year-olds, and finally elders are the smallest population here, and that's represented there in that chart. Charlotte-Mecklenburg crime statistics for the community. There were 47 homicides reported and compared to 32, which is an increase of 46.9%. 1,335 robberies were reported compared to 1,173, which is an increase of 13.8%. There were 223 rapes that were reported compared to 190, concluding in an increase of 17.4%. There were 2,746 aggravated assaults that were reported compared to 2,304, resulting in an increase of 19.2%. Burglary overall was up 16.7%, with 4,991 compared to 275, with an increase of 15.9 in residential burglary, 3,666 compared to 3,163 robberies, and an increase of 19.2% in commercial burglary cases, which is 1,325 cases compared to 1,112 cases. There were 1,635 vehicle thefts that were reported compared to 1,203, resulting in an increase of 35.9%. Total larceny cases increased by 5.4%. The numbers were 17,540 compared to 16,642, with the larcenies from auto up by 9.4% alone. 6,462 compared to 5,909. There were 184 arson cases that were reported compared to 124, resulting in an increase of 48.4%. Community diagnosis weaknesses. In this community, there's a large number of young pregnant women with very limited financial resources. The limited finances may mean lack of access to care and education, housing and transportation, and nutrition and safety. Weaknesses continued. This non-English speaking population may have a low level of health literacy. In this culture, men make the majority of the decisions, which makes women hesitant to make their own choices concerning their pregnancy. Community health diagnosis strengths. This Hispanic community sees health as a community issue and needing community involvement, not an issue to be held independently or even within the immediate family. Therefore, patient education becomes community education. This strength is what we are basing our intervention on. We want to have the group visit to provide information as well as correct any misinformation that may be present within the community. By utilizing the group model, we can be more aware of any misinformation within the community, and this also allows women with similar experiences at a comparable gestation in their pregnancy to reach out to each other via social networking. This network should continue to grow past the point of the pregnancy, and the patients can continue to support each other in the postnatal period. Further, there will be stages of childhood that their children can experience together going forward. Community health diagnosis strengths continued. This population spreads information throughout themselves, as stated previously. Education to a group of people would benefit many within that community. Interventions. Primary is to initiate group visits to the Spanish-speaking women at the OBGYN office within the first trimester of pregnancy, where we feel like there's a lot to learn. Secondary is to gain financial support and additional resources from local businesses in the community. Tertiary is to push for support at state and federal levels, continue to implement and grow the model, and seek out policies and resources intended for this population that are underutilized due to the lack of knowledge. Some questions. Are there any potential or actual problems? Yes, there are a large number of young pregnant women with very limited financial resources who may not have a very high level of health literacy and may have some unsafe practices related to their health and pregnancy. What areas are affected by the problems? All areas are affected in some way by limited finances. The access to care, transportation, education, nutrition, safety, housing, and much more are affected. What is the level of community awareness of identified problems? Community awareness is variable. Some have no knowledge of a problem, others have high awareness and blame the community, and others have a mindset that Well, this is what it has always been and what it will always be. Are the problems considered high priorities by the community? Awareness is crucial to the prioritization of pregnancy care and women's health in the community. Our priority is to increase the level of health literacy so that the patient and community can begin to advocate for themselves, as well as for the community as a whole. In addition, there needs to be allocation of resources and knowledge of available services. Asked to identify potential nursing or other health interventions to address these problems. And nursing education is number one. We have the knowledge and interventions needed to create a change, but the patients must be educated in order to work with the healthcare team and their community to make positive changes. And finally, our last slide here is just our resources that we use. We use the Centers for Medicare and Medicaid Services, Charlotte-Mecklenburg Police Department, Charlotte, North Carolina Neighborhood Profile, intersection of North Tryon Street and North I-85, and finally Women's Preventive Services Coverage and nonprofit religious organizations, also Centers for Medicare and Medicaid Services. And that is our presentation. We hope that you enjoyed it, and good luck everybody with graduation. Take care.